This is far from a debate because, as I mentioned yesterday, I give away the fact that I think MRI has a limited role in surveillance, but I'll try to make a case for where we could use it. Okay, treatment, we have to get past this thought. The patients have to get past this thought. Surveillance is treatment. You know, this is not watchful waiting. Watchful waiting is a completely distinct and different entity for which actually we've incorporated. I have a great partner, Howard Parnas, a medical oncologist who's thoughtful on this, and we actually put people on watchful waiting. But it's a very thoughtful discussion among multiple disciplines. This is surveillance, and we're rigid in our surveillance, and therefore the window to cure you, we hope, does not close by engaging on surveillance regardless of age. So it's always a balance, as we saw before in that nice little cartoon, the harms that we know we will impart and the benefit that we believe we will achieve. See, the harms are known. The benefit is uncertain. And so if we think about this, I go back to my theme of the comfort level, that trust biopsy, that barbaric approach to finding cancer, where we hope we hit the tumor and we don't know if we hit the tip of the iceberg, so we got the 6 amongst a big tumor of 7. We missed it completely. You know, that I understand when I have, senior urologists telling me, Peter, I'd rather take this out. That 30% upgrade bothers me. I've been in practice for 20 years, and I've taken out patients' prostates, Peter, and I know that a third of them will have worse cancer. How do I put them on surveillance? And how do you tell me to lower the age below 65 and put them at risk? Again, maybe MRI. So I'll just, a little disclaimer, MRI, next slide. This is what you can get in your practice. And these are images that you may get every day. And I show this to you because if you don't see the films that you're getting on your patients, you can get this, but you deserve that. By reading a report, I know everybody's busy, it's hard, you have a big practice. But think back to the days of urograms, IVPs, right? We used to put up those films, that was the intern's job, my job as a resident, and go through all those, and you could see when the ureter did not fill out with contrast. And you worried, was there a tumor in there? He had hematuria, should we do a retrograde? Then we moved on to CT urograms, and the reports came to us. And I can't tell you how many times I went to look at the films with my mentor at Hopkins, and the report says no lesions. But the mid part of the urine never filled. And when you ask the radiologist, did you flip him prone in the CT machine? Did you wait 10 minutes after you gave him contrast? Well, no. Well, how do you report this is negative? Well, I don't see a lesion there. But there's no contrast. And I can't tell you how many people come up to me at my courses and meetings and say, we're not getting the results you get, Peter. I said, how do your films look? Oh, I don't look at the films. I just get the report. Okay, so this stuff exists, and radiology, more than happy to increase their business platform, will seek out individuals and offer them. I have colleagues in Florida where they literally get knocked on the door, and they say, you're a big group, we can give you MRI in our practice. Because this is what you expect. You expect to see, here, this little dot. Now, we didn't go into this in detail, but on MRI, this is the peripheral zone. This is why my question to Dr. Lucia was so important, because this PZ comes around the top. There's a dark spot in that healthy, bright peripheral zone. That drop-in signal on T2, this is the T2 image, implies a cancer. But with one modality, it's difficult to interpret. So although it's too bright to see, on the confirmatory images, contrast enhancement, diffusion retina imaging, we see the same lesion. The level of suspicion is higher now. Again, a question about how we can miss these MR fusion biopsies. This area could be hard to biopsy without a guidance system. I want to show you that in this patient, who I'll give away the story, that was a cancer, who was a Gleason 7 cancer. Yes, we'll play that there. And what you can see is that, we have now fused, but I'm off. See this green line? It's a little bit askew of the prostate. We have to make some adjustments. I turn the probe around a little bit. This dark spot, now color-coded blue, is my target. Ultrasound would not even appear to have a difference amongst the echogenicity of the other lesions. This is not easy, but we took our time, and we got that spot sampled. When we hit that location, and we had good registration, and it goes back to yesterday's discussion about technical errors, what we found is that Gleason 7 in that young man, arguably would be indication for surgery. I mean, Dr. Kloss just mentioned pattern 4. What's the percentage of it? I don't remember. But if it's more than 10%, we're worried about this patient. It's hard to see for Dr. Lucia, but that's the biopsy. Come that next slide. So we actually chose surveillance for that patient. Now, maybe in the future we'll choose focal destruction. But the point is that all we've learned in the last lecture is that we're inferring volume of cancer based on the number of cores positive and the percent of the core positive with cancer. Imaging can give you that true volume, and then that can be used to select your patients. So I can skip through these review papers because Dr. Klotz is what I was highlighting out of respect for his work, and it's been summarized in the past lecture. I will mention, though, that, again, the criteria for entry is quite different, as he highlighted. Actually, this works out well for us because we're about 20 minutes late, Nelson, so we'll get back on schedule. We'll stay here for a second because he didn't really spend time on this because it's hard to boast, but again, the opportunities to say, I have patients in my practice 20 years out, that's remarkable, okay? And to have a large series. And so people criticize active surveillance. Well, it's a couple of hundred patients here. It's a couple of hundred patients here. As Dr. Klotz mentioned, it's thousands of patients. And again, these numbers are quite remarkable with nothing more than just clinical intuition and the urologist's thoughtfulness about taking on this at a time when the winds were against him because surgery was a much easier option. Now, this is the issue I have, and I won't go into it today, but the economic cost has to be assessed. So I think it's a value to save that one man's life, if we can. But I don't know if we can break the bank on that. I think selfishly, when we build devices, we don't think about cost, and I think about that one person. But that's something that we have to consider. Not my expertise is the economic modeling for this work. Next slide. So MRI, here we go. I think that, and I'll show some data following these next couple of slides. I'll show that we have the opportunity to distinguish a bit of a volume or grade change that theoretically could be a disadvantage for a person on surveillance with just a trust biopsy. I think the strength is in here. I've been told by many of my colleagues that the comfort level is improved, not just the patient to enroll on surveillance, but the physicians themselves to put them on surveillance. And I think that we can decrease the morbidity of active surveillance. So a criticism I'm sure we've all heard before is, how can you put a patient on surveillance, Dr. Pinto? He's 49. He may live 50 years. That's just too many biopsies over his lifetime. Infection, bleeding, erectile dysfunction. Everybody's nodding their heads, right? We've all heard this before. ED, subsequent biopsies. Can maybe the MRI decrease the frequency and allow us to be safely surveying and not include the morbidity? Well, I forgot to put on this slide last night because I fell asleep too soon. I'm on East Coast time still. But what I forgot to add was the mental anxiety and subsequent morbidity from anxiety that surveillance can add to a patient in regards to heart disease and other comorbidities, and maybe this can again be alleviated by MRI a bit. So this is some of the data we have. This is the confirmatory biopsy part, the ability to kind of pull out the bad players initially and have a more homogeneous cohort going forward. Next slide. And so demographically, we use the Hopkins, and as it was stated before, very low risk criteria. So keep this in mind. The numbers I will show are a bit skewed on the high side because we set the bar at that very low risk bar that Hopkins has established. And what we see is that when we have people in the community with a trust biopsy who refer to us for MR confirmation, we imaged confirmatory fusion biopsy. In 41% of those patients, they no longer met the surveillance criteria as defined by Hopkins. If we took something a little less stringent, we're back in that 25-30% range, as Dr. Kloss had mentioned, which we've seen before from upgrading, is a consistent number. Another thing is that the suspicion level on MRI does imply the degree of volume of cancer and grade of cancer. That's nothing new from previous papers. So we looked at a cohort going forward. Now, it's not a randomized trial, but we're looking at our series of patients. So we just modeled the active surveillance trials previously published, but in the MRI era. We wanted to see the progression. And so we have an expanded cohort. If you see under our definition of surveillance who's eligible, we don't have a cutoff for density, for PSA. What we do cut off is that the primary pattern has to be 3. There's no age criteria. So, I mean, I think the Royal Marsden has a pretty loose criteria in regards to number of course positive and percent course positive. And we just said, as long as you're not, beyond half the lobe feeling a tumor, so T2B, T2C or beyond, we'll include you, and we're not going to worry about the PSA. And so we have two categories. These aren't the largest numbers. I've been engaged in this somewhat recently, but we have about 38 patients who are intermediate risk. And if you look at the number of Gleason scores positive, we've engaged people with more than 2 cores positive Gleason 7, some 3, some 4. Now, I will say this, that if the patient ever says to me, I'm uncomfortable with surveillance, we offer them treatment. And we do quite a lot of surgery at the NIH. But these are individuals who seek us out in our protocols because they want to engage on surveillance. These are often well-learned individuals who've done their homework, and they either are seeking out alternatives or what they call a delay in treatment. So although, one can criticize that this person is not the ideal candidate, maybe we can learn a bit from them, but we're watching them very carefully. And in the intermediate risk, this is the issue. So the patients that are progressing, again, it's a combination of targeted biopsy alone. Our MRI has been criticized for being too good. We do find these areas. This is a big number. But other than that, the combined targeted biopsy and systematic biopsy hasn't shown to be a big improvement. So I do agree to diagnose cancer. We include 12 cores. I agree with that 100%. My hope is, again, decreased morbidity from surveillance. Maybe we could decrease from 12 cores every 3 or 4 years to targets alone. Well, this is premature data, very new data, but we're looking into this further. And maybe we can, again, drop the rate of erectile dysfunction if we limit the number of biopsies, decrease the risk of infection if we limit the number of biopsies. So this, to us, was very exciting, but it has to be flushed out further. And then progression, it's remarkable amongst all the series how similar we are, right? So, 30%, 28, 29, 27, 29, this really hasn't changed much. But what we did notice is that when we look at the hallmarks of progression, the indications on MRI, this is not metastasis. This is the number of MI progression definitions met by these patients. There are subtle inferences from MRI. So the T2 lesion gets larger. That's interesting, right? What does that mean? The diffusion-weighted imaging characteristics improve, or they get worse. That's a separate criteria. The ability for a lesion to emerge. We've had cases where we've had surveillance and then the lesions emerge over time. So those are things that we're looking at currently, and will take me quite some time, but we'll get there. So again, the predict progression, the MRI did stand out and had some role in these patients. I'll give an example of it. Interestingly, density, what you know going in is what you know coming out pretty much. PSA, as others have reported, has not been a big factor in taking off somebody from surveillance. But these changes, PSA and PSA density, doubling time velocity, number of cores positive, they trigger people to come off surveillance because of the anxiety factor. I think if I had no MRIs in my series and people saw a PSA change, they may rush to go forward with the change. I can calm or alleviate their fears with the MRI being stable. And this is an example emblematic of what we found in other cases. He's 61, his PSA is 3, and he had a 12-core biopsy, and it came back negative. But the MRI found the lesion right here. And those targeted cores came back with Gleason 7. Now again, I'm very critical of myself. Maybe we poorly sampled that lesion, and if we had done a better job sampling it with 4 or 5 or 6 cores, we may have had a different Gleason score. Maybe it was 4 plus 3. But there was 2 at the time. And 18 months later, he should have come back in 1 year, but he didn't. 18 months later, his PSA was relatively stable. The MRI did show progression, and we can see it even from the back of the room, that the size had increased. What I don't show here is that the diffusion-weighted imaging, the B2000 values also showed progression. And our radiologist said this is very worrisome. And they were correct that Gleason score was 8. Now, I don't know if we lost a window to treat this person, but he did have surgery, had negative margins. We're following him today. So MRI I don't know if it can find subtle changes, but it can find changes. And so when I conclude this lecture, I want to remind ourselves that the MRI is different amongst institutions. And you can have a 3 Tesla magnet, high strength, 1.5 is low strength. They can both be very effective, first of all. How you decrease the signal-to-noise ratio that you get from the images, whether it's a coil on the body surface or in the rectum or both, does impart a difference on your magnet strength. And then these parameters are all important. Spectroscopy has lost favor because it's difficult to reproduce and timely and costly. I think we'll see the emergence of what we call metabolic imaging. This is metabolic imaging, looking at the citrate choline levels amongst the areas interrogated within the prostate. But really, I want to focus on this diffusion-weighted imaging or apparent deficient coefficient maps. We have to learn the lingo in genetics. As we order tests like Oncotype DX or other biomarker tests, we have to understand, maybe not in granular detail what's happening, but enough that we can communicate to our patients what's going on. I think when you order MRIs, you should have that same level of understanding. So diffusion-weighted imaging is a restricted motion of water, and what that means is densely packed tissue will restrict motion, the MRI can see it, and it can distinguish among normal prostate, benign prostate, and malignant prostate. And it actually can correlate with Gleason grade. Next slide. Because if you look at the next slide, what we've shown is, in the publication that now is quite a few years old, but corroborated by colleagues of ours in Nijmegen, is that, and I know the error bars are wide and the box plots are very wide, but we test the radiologist who looked at the MRI and said to them, okay, we know what the pathology is. We won't tell you. You tell us what you think the pathology is. And for the Gleason 6s and the high-grade cancers, take away the 7s and a little bit of the 8s. We call that the brackish water, where the 6s and the pattern 3 and 4 come together. You can distinguish differences amongst that. This is an early look at this. I have no doubt radiology will improve. Again, my theme today is to decrease the morbidity of surveillance. Maybe someday they can improve to a point where the MRI can give us a better accurate description of Gleason score, decrease number of biopsies, decrease the frequency of biopsies, and help our patients. Next slide. Secondly, I think it's ridiculous that we have somebody on surveillance. I mean, this is why I went into this field when I was a fellow at Hopkins. My dad had a little bit of cancer, had surveillance, and they did a 12-core biopsy, and the label on the cup said left mid-lateral. And then next year he said, I'm going to come back and do the biopsy. I'm going to go ahead and re-biopsy this area, but I hope I'm in the same region. And if I'm not, the cup still says left mid-lateral, and there's no cancer this year. But were you close to that area? So the gift of the MRI targeted biopsy is that we can track location. So whatever system you use, for the most part, has a system to locate this. And then you can return back to the area. We published a paper with a resident of ours, student named Dima Raskolnikov, currently at University of Washington, where we felt high-grade PIN, as we were taught initially was to be rebiopsies, no longer important. We thought we shouldn't rebiopsy ASAP. So we took all the people that had ASAP and had the locations known on the biopsy. Remember, MR invisible, ASAP pretty much. And we resampled and saturated the area, went back to that spot, and we really found almost no cancer. And when we found cancer, we found almost always Gleason 6. Actually, Dr. Carter mentions, like, listen, Peter, this kind of makes sense. We know there's cancer in the area, but we wanted to rule out high-grade cancer. We just didn't see it. This is applying to surveillance. If your MR is processed well, you can go back to that little area of Gleason 6. We know MR doesn't see Gleason 6. Dr. Klotz has mentioned that there's a 20%, 30% miss rate. I would argue that in our series, that miss rate is mostly missing Gleason 6 cancer. Well, now, if you worry that this person is 40 years old, and you want to put him on surveillance, and Dr. Klotz said that there's a 15% chance that over his lifetime, 20, 30 years, he will progress, then you can go back to that spot, resample it in 5 or 6 or 7 years, see when it goes to that 7, intervene, and maybe that young man from his 40s to his 50s got married, had children, and you've avoided the harms of treatment, and you didn't lose the chance to cure him. This is the hope that MRI is going to provide us. So in summary, can we help select patients for surveillance? I think it doesn't hurt. And Dr. Klotz mentioned that in his practice, he would offer this to patients. We agree. Can it help the patient and the urologist feel more comfortable Engaging on surveillance, I think definitely yes. Can it predict progression on surveillance? I'm not so sure. We show some cases, but it's not very clear the subtleties of change. And can we afford to incorporate this in the paradigm of surveillance? I'm not sure. Maybe we should do a better job of figuring out, maybe for those, we call those the gray zones, Dr. Klotz's gray area. Maybe the gray area is where we impart this. I don't think we need this for the black left-sided areas or the right side, maybe the gray area. Maybe if we do less MRIs for the more appropriate patient, the cost won't be a problem. Again, so wonderful to be at an institution. This is the National Cancer Institute in Bethesda, Maryland. We open our doors to anybody who wants to visit and come. We actually have a hospital. It actually is, I know it's a protocol-based facility, but we have fellowships and residents from the area. Thank you.